start? Where is the best place for me to stand?
You want it to.
I'm going to start. I'm going to be walking around, but to start with, I'm going to introduce everything. So,
Okay. So we can have a live.
Camera. Where's the camera for this?
The camera is that, you're seeing the other sites as opposed to yourself.
Well, I wanted to see myself, so I remember who I am.
We can get you a mirror.
Actually, you can use your iPad. Now, guys, you cannot be shy. You have to get up to a computer. You cannot sit in the back. We got an extra one here. We got one here. Everybody's going to work in this conference. Nobody's going to laze. So,
Dr. Walker,
yeah, go ahead.
I would like to give a brief introduction.
Did I get your chair? Did I get your chair?
No, I'm going to stand.
Oh, okay.
So good morning, everybody, and good morning, everyone who has joined live from other sites across the globe. So we are privileged to have Dr. Patrick Walker with us today. So as we all know, he is the director of Arkana Labs, which is probably the largest renal pathology lab in the country, and it used to be known as Nephropath before. So just briefly introducing Dr. Walker, who needs no introduction actually. So he has more than 30 years of experience in interpretation of kidney and renal allograft biopsies. So before he became the director of Nephropath, he worked at several places. He was the assistant chief and later chief of the Department of Pathology and Lab Medicine at John McClellan Veterans Administration Hospital, and also vice chairman of the Department of Pathology and Lab Medicine at University of Arkansas. He also served as the faculty at Tulane University and University of Arkansas earlier. So he is very widely published, and most importantly, he is widely acclaimed as a very respected teacher, and he has won several awards as best teacher in different institutions wherever he has worked. So we are very privileged to have him today. So good morning, Dr. Walker.
Good morning, everybody. And this is an interactive conference, so you cannot just sit down and expect me to lecture like it's 1100 and we're in the new school, which in the new school in Oxford is was founded in 1100. So it's not like the new school in New York, which was founded in 1955. That new school was in 1100. So the way they used to do this was the fancy guy would come in with his robes, because he was the only one that had books, and notice it was a he, and he was only talking to he's. But he would come prancing in, and there'd be 400 people in the lecture hall, and he would sweep in and spit out knowledge, and everybody would scribble with their pens and keep dipping in ink and get that stuff down. We don't do that anymore. It's, there's that thing, some of you have heard of it, it's called the internet. It's kind of fancy. I know some of you don't know about it, probably. But just in case you didn't, this is why we're doing it this way. This is an interactive conference. So we're going to work together on some cases. The goal of this seminar is not to cover the material. If you get through 2 cases and you said, well, that's all I could do and that's what I learned, that's fine. Because what's on the sticks or the thumb drives that I brought are our lectures for all 5 cases. So you have references, a full lecture that has all the answers in it. If you would ever, for whatever reason, you'd want to actually go back and look at the answers and look at more details, you're welcome to do it. But rather than do that, let's pretend we're on morning rounds and we're in nephrology. And this is set up just like Renal Biopsy Conference that we give all over the country now. We do webinars all over the country for standard renal biopsy conferences, and that's what this is. So when you open up case 1, don't open up the one that says do not open until after the conference. Open up the one that says open first. If you open up the one that says open first, you will now be able to begin working your way through a case. Now the best thing to do is to have 2 or 3 people. Like we got 1, 2, 3, 4, 5, 6, 7 people here, 8 people. He's going to work with our offsite people. So if you work like 3 at a table, 3 or 4 in a group, then that works best because this is like word rounds and you're the medical students or the interns. And you're trying to figure out what it is before the staff guy comes along and asks you the answers or starts to go over with you. Now, one of the things you got to understand, I'm a nice guy. So I'm practicing my Brooklyn. My kids live in Brooklyn, okay, this is the way it is. Frankie next door, he works for the mafia. So I've been told, you greet Frankie. So what you gonna do about it, Frankie? That's all I got to say. You know, that's all you just say to Frankie. You just read him, you know, how you doing today? Okay, all good? Okay, good. All right, so I'm a nice guy. We're just gonna do this interactively. You guys are gonna work. Everybody's gonna work. Your offsite people are gonna work. I'm gonna walk around. Now, the history is lengthy. Get through it. Go back and forth into it. Take a few notes if you need to in your head or on a note app or something. And then I'm gonna walk around. There are 5 cases. So at the end, so at about 20 of, I'm gonna stop and I'm gonna start doing it interactively as a group. So everybody gets to work through it kind of quickly. And at 5 of 9, we are stopping. You guys have places to go. And things to do, things to get done. So go ahead and get started on the case. Work together. The key is working together. I'm gonna shut up, let you get started, but I'm gonna bug you. So go ahead and just work your way through it. Talk amongst yourselves. Don't get verklempt. So our guys on site, are they going to be able to work through it unless we help them?
So at BI, can you see the screen? Wait, can you see the screen?
I'm only going to open on,
Oh, they can see the screen.
So if they see the screen, then you work through it with them.
Yeah,
Or one of
so,
us can work through it.
and actually, they can talk to us. You can ask them directly, so they can talk to us. So there is way there, and Wending there, there are 2 residents.
But the thing is, somebody needs to sit here and work through the case with them.
Okay.
So if it's not going to be you, get one of the guys up here and they'll be part of their group. That's the way to do it. And the big thing is if they can hear us.
Yeah, they
But actually, I really want them to be working. Okay, so let somebody come up here and work with them and go through the case, because we've got to press the advance button so they can see it, right? All they're seeing is case 1. So let's go ahead and get them started.
So yeah, BI way, so you have to work on this case with me. So I will work with you, like this case 1, whatever history is there. So we are going to work together. Thank you.
Somebody help the girl. We got some long rangers here.
but
Well, but everybody needs to, let's get some more sticks.
So we are supposed to be.
So we
Yeah,
have
work
a
with them. The only things on here is.
65-year-old male who is a retired judge with edema. And this is the history that we have for this patient.
Sticks. Guys gotta share sticks. There's a stick.
Oh,
And it just says, guess what? City Express.
okay.
I know it's a surprise. So she's already working. And you know this is.
So for those who are not, who are online, so as you can see that we have a team of people, so all their computers are on and they are discussing the cases. So it's a little different from what we do every day.
No, I just want to say that's not.
So this patient is symptomatic with edema, normal urine output.
Yeah, I know, right? What is it from?
So no history of osteoarthritis. So there is history of bilateral osteoarthritis for last 5 years. One brother expired from liver disease. Okay. So he's a retired judge. No erection. So DP is high. There is edema.
What is it?
And here are the lab values. Creatinine 1.46. 4+ proteinuria.
Plus or minus 10%.
Yeah.
So it's actually 1.5.
24-hour protein is 12 grams. So there is, I guess, nephrotic range proteinuria here. So Wei, can you hear me? Yeah, you are not loud. I cannot hear you well.
So what if he goes from 0.8 to 1.6?
Yeah, it's very feeble.
What?
I said I don't actually understand.
You don't know water's long.
So there is nephrotic range proteinuria, as we can see.
It works every time. Of course, what you say is,
Yeah, and then you also-
about 40 to 50%. And the reason is it's a log scale, so if you go from 1 to 2, you've actually lost 50%. You go 2 to 3, you've lost about 25%. What about the normality?
So that's what we have, I guess.
Especially
So the idea is to build a story from here. So the problem list doesn't show anything.
So think about it.
So yeah, Dr. Walker, so we have been reading this so far, and so we don't have a problem list,
Yeah, you're
right?
supposed to generate
Okay.
one, but I gave you one on the next slide.
Okay,
Just think about what it could be.
okay.
You got a bunch of problems.
Mm-hmm.
This guy's got problems.
Okay.
So what's the normal? Yeah.
So I guess we have to generate a problem list.
Well, less than 3.5.
Well, that's, yeah, but that's not normal. What's your normal protein output every day? Less than 300 milligrams. So the fragment is probably.
We can go back and look at it again.
This guy's.
So 65-year-old male, so symptomatic for 2 months with edema, then some history of
Right,
medication.
so there you go. So yeah, this is straight up. Let's not make it more than it is.
Okay,
So we got, what did you got? You've already said.
High blood pressure.
So go ahead.
and there is nephrotic range proteinuria.
Think about stuff from product syndrome. Mine's always stuff. Oh, we're looking at what stain is that? Jones. So we're gonna keep-
Okay. So this is the renal
Did I
biopsy.
interrupt you? Are there any spikes?
But this is so
Make it bigger if you want.
validating mesangial hypercellularity. That's what I can appreciate. Wade, do you want to add anything here?
No, the answer is no. Look here. No, you know what's wrong here? It's very difficult to see a glomerulus. Look at me. It's difficult to see a glomerulus in 3 dimensions. Took me 2 years. So I cleaned it up. So I got a goal. Here's my glomerulus. Here's where the arteries come in. Here's where the proximal tubule goes out. So it depends on where you do this thing. That's where the arteries are coming from. So what we've done is, imagine it this way, we're looking down at the glomerulus, our head's about in here. And we're looking right at where the inferior and go in and out. And so that's why it looks so funny. That's why they always look to the periphery. When you're looking at cellularity.
So what I can see is that there is probably increased mesangial cellularity. Is there some collapse? I'm not sure about it.
Okay, keep going. You guys are doing great. What stain are these? What are you looking at there? Yeah, see, we don't use an H&E much. Why would we use an H&E? What are we looking for in a renal biopsy if we're using H&E? And cellularity always overcalls. So think you've got 4 categories to look at any kidney biopsy.
So there is IF here.
What 4 major
This is IgZ.
facets or parts of the kidney are you looking at? I'm way up here at the top. So glomerulus, tubulus,
This is C3.
and vessels. The H&E is great for everything that's gone. The glomerulus doesn't do it.
Kappa.
What you can see on the left is inflammation. You really can see inflammation.
Lambda.
That's why you can see so much of everything. Really, this is when you read your cellularities on RPS, and there's none, just so you know. So
Okay.
you're already on your IF. Notice on IF, if I don't tell you what it is, if they put a thing on the board, they don't tell you what this is, well, we already know the board sucks, so that would be typical. I'm not gonna get that. But they're all green. It's green. It's fluorescent, right? So if I don't tell you what that is, you're gonna.
We can go back and have a relook at the H&E if anybody wants to.
So that's.
So it's not H&E, we have the PS. So here are the trees on the early.
Negative or positive. And if it's positive. It's either granular
Yeah.
or linear. And then you do all these different stains, where you apply that criteria to each stain. So IgG, is that positive or negative?
So this is the other image that we have.
This is stain that's just dropped, precipitated onto the soil. So what you are seeing, these are real.
This is the other image.
This isn't something I manufactured for publication.
These are all
Prettiest pictures.
Yes.
This is real.
more granular.
This is so positive. Now, is it granular or linear? Yeah, now here's the trick on granular or linear. If you're not sure, always say granular. Why? What is linear? What disease is characterized by linear gene?
Linear IgA.
No, not IgA. There is a linear IgA. That's way down the line. It's so rare. So what is linear IgG, guys? You see linear IgG on immunofluorescence cancer diagnosis. It's good pasture or anti-base membrane antibody syndrome. You are more likely to be hit by lightning in the U.S. than you are to have good pasture syndrome. That's how few cases of good pasture will occur in this country. There'll be about 400 cases a year of good pasture in this country. So that's why if you're asked linear or granular, don't say linear. Say granular. Okay, but that's obviously granular. See, those aren't.
So he says, just to be a little loud to everyone, that it's granular IgG positive.
Okay, now go on to the next slide. So this GNC3 looks the same. Next. Kappa. Next. All right, so what if Kappa was not positive and Lambda was? Now we got another whole problem center. Those are now the rare diseases.
Mm-hmm.
But this isn't a rare disease.
Mm-hmm.
So Kappa Lambda positive. Would we expect that with IgG? Yes, because the IgG molecule has a kappa and a lambda on it. So
Right.
we expect that. So kappa lambda C3G. Now go to your next pictures.
Okay.
So that's your IF zone.
So this
what
is
have you
the,
done? This is an immune complex mediated event on a background of a pretty normal looking light. But it's immune complex. What disease have we ruled out?
So he says it's immune complex.
All right, what's the differential diagnosis of nephrotic syndrome? Idiopathic nephrotic syndrome in an adult. Name any disease. If you don't know anything, say, I don't know. It's fine to say wrong.
I mean, like, FSGS.
That's one. You're next. Differential diagnosis of idiopathic nephrotic syndrome in anybody. So he took FSGS. We're going to give you Walker's second Walker.
Membranous.
Membranous. Very good. Yeah. Membranous proliferative is in there, but it's down the line. There's three biggies. Here's, you can always remember things in threes. Okay, guys? Threes.
Yeah.
Minimal change, FSGS, membranous. Those are the three biggies of the primary or idiopathic forms of nephrotic syndrome. So if I've got minimal change by light, an immune complex by IF, I've already made my DX. Which one is it? Is it FSGS? It's normal by light.
No.
You can't do that. It can't be minimal change because it's got a positive IF.
Mm-hmm.
So it's membranous. We already made our DX, but we're going to throw in the electric microscope. Okay, so the first thing you have to do when you get to the electric microscope is figure out where you are. What space is this? This is urinary space.
This is urinary space.
So the way you think about this is, here's the mesangium, here are vessels. Think of the tubing. So now I've got a support structure for the mesangium. The vessels are wrapped around the tube. So mesangium sitting here, here's a vessel coming out of your face and going back in. This is another thing. We talked about 3D. Trying to understand this in 3 dimensions took me forever to figure that out. It's not very slow. I do not have but one histology allele. You know those guys with 5 alleles or 6 alleles for histology? You know those geniuses? I hate them all. Oh, no, I love them. They're great. Yeah, I have to work about 10 times as hard as other people to see things. So when another guy will look at me and go, oh, that's obvious. I go, no, it's not. Shut up. So send me over here. So capillary space. Yeah. Now where's the problem? You got to look at all the pictures real quick. Go ahead and go to the next one. It's too low power to figure it out. Oh, all right, but there's the GBM. Now, which side of the GBM are we on? You've got to figure out which is the capillary space, which is the urinary space.
Excuse me, Dr. Walker.
Yes.
If you want to use the mouse so that and if you can show it there, then the whole audience can explain and
Good,
see it better.
Hi, guys.
Yeah,
Oh, I'm not.
and also the globe, the online audience.
I can give you the chair, but I'm blocking the mouse. There it is. I'm fine.
Yeah.
It's a fast moving mouse.
It's been.
Capillary space. Urinary space. Oh, hi, Mike. Mr. Mike is right here.
How do you pay for those?
Glomerular basement membrane,
Actually, it's urban or the electric.
mesangial region. So, where are the deposits? They're on the epithelial side. The epithelium faces the urinary space. The endothelium lines the capillary space. Everybody knows that. Endothelium lines the capillary space. So, where are the deposits? They're closest. Come here, mouse. Come here, little mouse. They're closest to the epithelial side. Let's go to the next one. So now we got a problem. When you look at real high power, is this the urinary space or the capillary space? Well, it's the urinary space because these are foot processes. This is the capillary space because you can hardly see the fenestrated endothelium. So the deposits, here we go, we're still in the urinary, that's the podocyte side. So these are the deposits right there. That's a big black deposit. This dark stuff here is actually the podocyte sticking its nose in there. So there's an electron dense deposit. There's an electron dense deposit sitting on the subepithelial side. Now we'll just go through these zippity-doo. There's more of the same thing. So we've got urinary space, capillary space, deposits. Foot process effacement. Mesangium doesn't have deposits. So there's your summary. Okay, guys, as a group now, what special stains are we going to request if we have a known diagnosis of membranous? This, if it's going to be on your boards, this is going to be on your boards. They don't ever ask simple stuff anymore. No, they never have. They've always asked the most esoteric, newest stuff. So this has been known since about 2013. What special stain has to be requested once we have a diagnosis of membranous? Anybody know this? I don't expect you to. It is the phospholipase A2 receptor immunohistochemistry stain. It will also be the thrombospondin-like molecule THSD7A, which is, of course, on the answer sheets, on the other, so you don't have to busily write stuff down. It's all in the answers. And actually, I think I've got it on the next slide. So let's go ahead and go to the next slide. Oh, it ended. Oh, no. It did end. That's the way it's supposed to, because that's what introduces the lecture topic on this case of plate 2R in THSD7A, which we're not going to talk about till we're done. Let's go to the next case. So you guys got it right. Everybody picked out membranous, and this was straightforward. The interesting thing is this patient is from India. You could postulate a whole bunch of stuff about what disease is not common. Well, it's more common in New York, but what disease is much more common in India nowadays than is in the United States. That is, I mean, all you got to do when you hear that is say TB, right? And membranous and TB go together. So that would be one thought. Okay, next case, go to case 2.
Okay. So yeah, just so that it is more interactive, I think we can discuss more on the screen maybe, so that everybody else.
You guys want to do it that way?
Yeah, we should.
I mean, it's okay. It's okay. What the way this works best, by the way, is if you have several. Like normally I travel with Sri Sharma, who visited you guys already.
Yeah.
When Sri and I go together, listen, it is Mo, Larry, and Curly. I play 2 roles. I'm both Mo and Curly. And know that if you don't know the Three Stooges reference, look it up. It's a lot of fun. Okay, so let's go ahead and go to case 2. And we got a sick person. Back up. Let's back up the slide. I want to know how old this guy is, or her. Just back up. Okay, so we got a 58-year-old male with cough and malaise. One of my favorite words, malaise. Malaise. I just don't feel good. Okay, let's go ahead. And he's 20 days. Low-grade fever, dry cough, doesn't feel good, throwing up. I'll tell you this. You do this for 20 days? He hadn't been doing that for 20 days. You do that for 20 days, you're dead. So he hasn't been nauseated and vomiting for 20 days. Decreased urine output, not a good plan. He doesn't have anything to make you think. These are all symptoms of vasculitis, lupus, hemoptysis. He's got some symptoms. He's got a dry cough. He doesn't have diarrhea. No history of NSAID use or other nephrotoxic agents. That's critical because the next thing we're going to find out. He is a diabetic and hypertensive. He's got, now this is why you know this case too is from India. What's COX? Well, we got some people from India here. So COX, what is COX?
Tuberculosis.
Yeah, it's just another name for tuberculosis. And just so you guys know, I travel to India every year and generally visit 4 or 5 places. I've been doing that since '96. When I went in '96, there was no such thing. There was an electron microscope, sort of used like a museum there. But I travel a lot, and so a lot of the cases that we use, I just go to India, so I use the cases that and turn them into India cases, or they are from India. So this guy's creatinine baseline was 0.1, was actually 1. We were laughing in here a minute ago about the use of the 100th place in creatinine. The creatinine test is sensitive plus or minus 10%. So in reality, that is a creatinine of 1. That's 3 months ago. Normal urinalysis 3 months ago. We're going to find out more in a minute. Nothing here. I always love it when we have to say teacher by occupation. He was a teacher by choice, by occupation, no, he's a teacher. Smokes 20 cigarettes a day by numbers, 20, not 21, 20. Physical exam, he's a little hypertensive, he's breathing a little too fast, he's edematous again. Again, nothing that we're thinking about for lupus. Okay, Walker's first law is if asked a percentage, always guess 15, 50, or 85. So I asked a minute ago, if you go from a creatinine of 1 to a creatinine of 2, what percentage of your renal function has been lost? If you have no idea, the answer is about 50%. Now, you could have guessed wrong and thought, well, that's only about 15%. But in fact, you got to remember, creatinine is a bad measure of renal function. It's more of a logarithmic kind of scale. So 1 to 2, 2 to 3, each time you're losing more and more. So 2 to 3 is 25% kidney left. So, all right. And the other thing in renal, if asked a differential diagnosis, which I did a minute ago, and you all put everything together, you can always say lupus. That's Walker's second law. In any renal condition, if asked in the differential, what should be included, you always can put lupus. You can always say, well, it's not likely, but this could be lupus. So in spite of all this could still be lupus. Lupus should always be in your differential. All right, so we got a few physical findings. He's hypertensive. He's got left ventricular hypertrophy. Big whoop. And now his creatinine is 7. Okay, creatinine of 7. He has about 5 cc's of clearance at this point. Normal clearance is about 100. This is dialysis necessary, most likely. His albumin is a little low. His urine output a little low. And he's got occasional red blood cell CAS. All right, red blood cell CAS, renal failure, and hypertension. What syndrome are we in? There's only 4 major renal syndromes. We just did the nephrotic syndrome. So it's either acute nephritic syndrome, and I always say the nephrotic syndrome, and acute nephritic syndrome to separate the O from the I. Who thought it was a good idea to say nephrotic and nephritic? It's separated by 1 stupid letter. I could never remember that. So I've added a few words. Acute nephritic to remind me that it's usually acute. Now, there can be an acute nephrotic. But, okay, so what's the other syndrome this could be? Rapidly progressive renal failure. Now, in pathology terms, that's rapidly progressive glomerulonephritis. What's the 4th major renal syndrome? Asymptomatic hematuria and proteinuria, or proteinuria. So there's 4 major syndromes: nephrotic, the acute nephritic, rapidly progressive, and asymptomatic hematuria and proteinuria. Once again, these are pretty straight up. There's no reason for you guys to know, especially guys going into doing cyto, but this is fun. It's interesting. This is the medicine part. So we're looking at probably rapidly progressive because this has been going on for about a month. Acute nephritic is days to weeks. Rapidly progressive is weeks to months. So notice there's an overlap. Probably rapidly progressive. Now that's backwards, isn't it? Rapidly progressive. Rapidly progressive sounds rapidly progressive. And acute just sounds like, that's acute, man. I better get to the store. Okay, got there. It's backwards. Rapidly progressive actually comes on you slower. than the acute. Just FYI. Man, they did a lot of stuff here. Look at all those serologies that are negative. They did the complement workup. Uh-oh, we got an ANCA. P-ANCA is weakly positive. Now, if we get a positive ANCA, we've got to, who are all our clinical lab people? What do we reflex to if we get a positive ANCA? Anybody in clinical lab know the answer? You reflex to MPO and PR3 ANCAs, and that's an ELISA test. It's much more sensitive, much more specific. That hadn't been done yet. Ultrasound showed normal kidneys, chest x-ray. So we got a bunch of problems here, but let's move along. We just heard a bunch of them. We could generate it. Differential diagnosis of rapidly progressive glomerular renal failure. All right, guys, when we do renal biopsy conference, this is where the fellows, the renal fellows, really need to know what they're doing. You notice how non-specific all the glomerular disease syndromes are. We did nephrotic syndrome. We got everything from 70-year-old people with membranous to 2-year-olds with minimal change disease. These are very non-specific. Rapidly progressive renal failure doesn't have to be a glomerular disease until I see red cell casts. Red cell casts means a glomerular disease, except when it doesn't. Okay, but if I see red cell casts, you always say this patient has a glomerular disease. A small percentage of patients with red cell casts have acute interstitial nephritis. Just FYI. Again. All right. Renal biopsy was done. Okay, the very first picture up here, guys, what are you seeing? This is an H&E. The H&E section is used primarily so that we can get the lay of the land and look for inflammation. So we've got tubules. We have a little background inflammation, and we actually have red cell casts. You actually see your red cell casts on the Jones Silver and the H&E. Red cell casts on urinalysis are not red. Any of you ever looked at a urinalysis, and I don't know why you would have. Clinical lab looks at them all the time. They never recognize one. But I've looked at lots of red cell casts because I work in renal. They're brown. They're not red. But in a kidney biopsy on H&E and Jones, because we're using eosin on both stains, we see them as red. So there's a red cell cast. Now we've switched to the PAS stain. First of all, what most people focus on right away is that there's a lot of inflammation in here. So let me just tell you, there's a lot of tubulointerstitial inflammation, but that's not where we want to look. We want to look at the glomerulus in this case. So what we have going on here is fibrin and cellular reaction to the fibrin. Fibrin and cellular reaction to the fibrin. Over here, not much. Anatomy lesson. That arteriole is coming straight into the glomerulus. It's taking a straight dive. So that is the afferent. The afferent comes and makes a straight dive in. The efferent comes out. Here's our glomerulus. The efferent comes out and wraps around the glomerulus. So it comes out and makes an immediate turn out of the glomerulus and heads for the proximal tubule. Come here, mouse, which is on this side. So the takeoff point's over here. So the efferent has to come out, wrap around, and get over here to feed the proximal tubule and all the tubule, the nephron. Here's another glomerulus. Fibrin and cellular reaction to the fibrins all over the place. This is a crescent. This is a necrotizing crescent. Fibrin is necrotizing material, and we're cellular reacting to it. The trichrome stain is very bright in this case. It's a little bit too much, but fibrin lights up bright red on a Masson trichrome stain. So all this brilliant red inside the glomerulus, that highlights the fibrin that we already saw. And this looks more like a crescent. They don't always have to look. Those first ones didn't look like a crescent at all. They looked like fibrin and cellular reaction. That looks like a crescent. There's still a bunch of fibrin in here. So crescentic GN, it just goes forward. Oh, wait a minute. What's this? That's an arteriole. That's an interlobular. And if you know that anatomy, you've got way too much time on your hands. You should be learning more cancer and other stuff. But that's an interlobular interlobular artery. The afferent comes off of that and is an arteriole. But it's got vasculitis in it. It's full of fibrin. And you say, but Walker, where's the inflammation? There isn't much. This is mostly fibrin right here. And what we've got going on now is we've got a glomerulonephritis and a vasculitis. And there's more red cell casts, bright red inside tubules. Just to finish it up, I couldn't stand it. One of the things about this conference is, normally if you're working on your own, I give you stuff I got. This is way too many slides. If you're teaching this as a lecture, you cut these slides down to half. But if you're doing it interactively, you get to see what we see. So that's what it looks like on a Jones. My gosh, that is an absolutely stunning image. One of the things about pathology, all of us are in pathology. This is the best time ever to be a pathologist. One of the good things is morphology isn't going away. I was told in 1974, when I left my medicine internship to go into pathology, I had a 30-minute tirade by the chief of medicine, mocking me, telling me how stupid I was to go into pathology. These are the days before we took care of residents, okay? They were very mean. And my staff was very mean, and I was very mean back. As you can tell, I probably don't take that very well, and I made them look like buffoons frequently. Because if you got a cardiologist who's ward rounding with you, and you got a renal patient, I'd read up on all the renal. And then when that guy would pimp me, I'd pimp him back on the renal. They didn't like me very much. So he gave me a 30-minute tirade. He said by 1984, nobody will even be doing histology anymore. There will be no more histology, and we will own the clinical labs, meaning medicine. You're not going to have a job, Walker. I said, okay. In 1993, I was invited back to give a Fettschrift, which is a very important lecture honoring the guy who I was trained with at Indiana University. And I walked by the chairman of medicine, and as I did, I said, I know you don't remember me, Walter, but I'm the guy you told was going to be out of business. But who's up here giving this talk? Well, that would be me. Have a nice life, and walked on by. I've never been a very nice guy. I said I was a nice guy. I'm a liar. But I don't take to that well. I just don't take to that well. All right, enough of that. And here's what I mean. What is it? I love this. I love looking at the beauty of pathology. We're weird people. Isn't that a lovely cancer? I mean, we're odd. You know, boy, that was a fascinating autopsy. Really? That's a party killer, baby. Don't bring that up at work afterwards, you know. All right, so this is silver stain, and you can actually see that the basement membrane has exploded here. Boom! All right. Immunofluorescence, we had a little discussion. It's either positive or negative, linear or granular, and the mistake you're going to make is to think that's linear. You're going to think this is linear. The way you don't make that mistake is compared to Bowman's capsule, and you can't see it very well, but look at this. If it's this bright right there, that would be positive. This is normal G background. When it's positive, it blows you out of your chair. It just boom. So on the other slides, I have pictures of true linear. And this is the crescent. You can do a lot with well-done frozens. That's fibrin, same glomerulus. See how you can now be sure that's the crescent? So there's our summary. What's our diagnosis? What's our diagnosis? If the immunofluorescence is negative and we have a bunch of crescents, what's our diagnosis? Crescentic glomerulonephritis. Now there's three types of crescentic GN. We've talked about good pastures or antibase membrane antibody. That's type 1. What's type 2, if anybody remembers? It's immune complex mediated. So in lupus, you can have crescents, right? And the third one is pauciimmune. That's what this is. So when you see a pauciimmune crescentic glomerulonephritis, we didn't used to know what this disease was. When I started, we just knew it as those three categories. We didn't know what caused it. So what about that positive anchor? So this is, it could be that, but what you really should say is ANCA-mediated pauciimmune crescentic GN, because all the rest of that is a syndrome. So Wegener's, microscopic polyangiitis, those are clinical syndromes. So in this case, he's got pulmonary manifestations, he's got renal and vascular manifestations. This is more of what used to be called Wegener's. It is now called PGA, polygranulomatous angiitis. Yeah, see, it's stupid. Part of the problem is we need to get rid of Wegener's. Do you guys know why we're getting rid of Wegener's? Wegener was a Nazi. He did experiments with Dr. Mengele. He was the medical examiner at the Lodz ghetto in Poland. And who knows what happened to all those patients there. And this was all well hidden. He'd already gotten a major award. Now that we know about it, we're getting rid of that name. He is anathema. He is somebody that should be wiped from the history books. That's our diagnosis on case 2. Now, what would I normally do? Now I bore you to tears with statistics, more pictures. That's why when you work through a case, and actually if you were doing more of the work, you can see how this would go as a much more, and then you still got plenty to do. So case 3. Tell me what let's do. Let's switch to case. So we've already talked about 1 and 2. And we've really covered those. Those are straightforward cases. Open up case 3, not in this folder, but in the do not open till after folder. Because it's 20 of, we have 15 minutes. We've already gone through what to think about in the first 2 cases. So this one we're going to work through, and then, so 48-year-old with weakness, gee, that sounds like a pretty typical syndrome, doesn't it? We get a lot of that. He's got a headache each morning for a month. He's got, now, wait a minute, we got a neurorenal syndrome going on here, don't we? A neurorenal. By the way, there is a X-renal syndrome for just about, there's a cardiorenal, pulmonary renal, there's a dermatorenal, there's a GI renal. Sorry? Hepatorenal. Hepatorenal is the, I don't say the easiest, it's usually just an acute tubular injury pattern, but not always. There's some very interesting things. So you're right. All that stuff is true. So we've got a bunch of stuff that when neurorenal isn't very common. Loss of coordination and frontal headaches. This is all the history. Everybody can read it. See, but look at the 3rd line. This guy's got neural problems here. He's not been worked up. No history of diabetes. In this day, you always have to put it in there because it's assumed everybody has a history of diabetes by the time they're 50 on a renal biopsy service. Here's his family history, no help. He works on the railroads. Father is an engineer for the railroads. I always have to translate centimeter and weight. Sorry, guys, never was able to convert to the metric system for that. If you tell me something in centimeters, I have no idea how much that is. This is not a big guy. He's 5'3", 150. Blood pressure's up. Respiratory rate's okay, pulse okay. Nothing else going on. I always love it when they put up the electrolytes. If you've got abnormal electrolytes, you don't need to be being worked up for renal biopsy. You need to be in an ICU. You need to be being stabilized. So kidney guys are all big to put these electrolytes up, and I was going, oh, next slide, please.
Will you wiggle the connection a little bit for the TV? Because if we get to pictures, this isn't going to look right. The background's supposed to be white. Just the connection for the VGA.
This guy, I probably stepped on it.
Well, it's the one actually going in the back of the computer. It'd be closest to the other one. Yep, there we go. There.
You got it?
Yeah.
Nope.
Kind of.
Back to white.
Back.
I stepped on that.
Okay. Yeah, it's
Right
better.
there. We got it.
Don't touch it. Back away from the cord. So he's got some protein. Now we talked about this earlier back in the back. Normal protein 300 at the top milligrams. So 1.5 grams is definitely abnormal, but it's not nephrotic range, which is 3.5 grams. Just arbitrarily decided, but that's actually, by the time you get to 3.5 grams, you're having trouble. A lot of good numbers here. Plates are okay. We can do a kidney biopsy. That's always the important thing to know. We can do a kidney biopsy, yeah. His hemoglobin is low. I always love it when they say, people still say liver function tests. I hope you guys don't say that. We've been trying to get rid of that for years. It's liver enzymes. It's not a reflection of the function of the liver. It's a reflection of injury to the liver. Oh, that's one of my pet peeves. All right, other stuff up here you can read. One of my other pet peeves is a lecturer who does this. Other studies, Bueller. Chest x-ray normal, ultrasound, liver, biliary system. You know, this is where in Arkansas we're armed and dangerous. We pack in Arkansas. No, we don't really. That I'm playing to your stereotypical image of Arkansans. But that's when you really want to pack. Just take them. I know better. Just, you know, a little bit, one of those guns that the veterinarians use to bring down the tiger. Just bring him down. Then you can all go back to work. Don't read. When you got, every pathologist teaches, don't read the slides to people. They can read them faster than you can. They're not in first grade. So don't read slides. Let people read it. You point out what's important. There is a problem here in his EKG. Now, people still do electrocardiograms, and it's still important to know how to read them besides just letting the machine do it. This guy's got trouble. We now have a neurocardiorenal syndrome. You know what? Do you know how easy it is for internists to miss this? Very easy. This was completely missed. This is a biopsy I read. This biopsy was completely missed by internal medicine, by his family physician, by his nephron. Renal biopsies are still needed. By definition, renal biopsies, we're going to do 65 renal biopsies today. We read diagnostic kidney, we will read 65 kidney biopsies today at Arkana Labs. All over the country. 15% of those will be kids, 15% will be transplants. The rest are diagnostic challenges. All of them are diagnostic challenges. Every single case. This was completely missed. The renal biopsy is going to give you the answer. Let's go to it. Okay, for people who are thinking, once we got him in the hospital, some people started doing some workup. We did a head MRI, we had a head CT. They were thinking that he's got premature ischemic vascular disease. That's what they were thinking. Remember, this is not an old guy. Problem list, we've listed it, differential. Hello? Guess who thought of that differential? Well, that would be me, not them. This was not on my sheet. When I see cardio, neuro, renal, I think of a storage disease called Fabry's. You want to see a board question? It's coming up. This is not as uncommon as good pastures. Fabry's is a lot more common than good pastures. But they might just pop a Fabry's on your test. So 50% global sclerosis, we're already in deep trouble kidney-wise. And at low power, we see fibrosis. Here's our trichrome stain. This is a true low power. We're not supposed to see any blue. It's all supposed to look like this area right here. None of this blue stuff. There's a lot of blue, which is fibrosis on the trichrome stain. Not a good plan. He's got arteriosclerosis. Look how thick the intima is. He's got microcystic tubular dilatation. That's a completely nonspecific finding seen in any scarring tubular disease. His glomeruli are starting to sclerose. So this is the normal area, and this is an area of sclerosis. So by definition, what's the diagnosis here on the kidney biopsy? Not all glomeruli have it. Only a small segment has it. This is focal segmental glomerulosclerosis. You just showed us the biggest wastebasket in renal path. We've got 2 minutes. Hurry up. High power. This is where I first saw it. Right here. These podocytes are big and foamy. And they're in areas of sclerosis. No big deal. Big, foamy, capping podocytes. Still don't see it very well. Look at this. That's a picture they could put on the boards. That's Fabry's. And that is subtle as heck. If they put this up here, guess. Just guess. You're not going to get it. You shouldn't get it. If you're wasting your time learning this detail, unless you're a true gunner, you know, now we don't use oil. We use a 60X dry. So I'm getting a 600X here. That is a foamy podocyte. That's a storage problem. Now this is PowerPoint, Photoshop to bring it up even higher so you can really see it. Really see it. More pictures than you need. IgA is negative. G is negative. M is negative. C3's got the typical vascular pole staining, which is normal. Kappa, lambda. Here's the actual stain that shows it. This is the toluene and blue stain section stain for EM. And this is the lesion that it shows as foamy on the other stains. So the tall blue stain on a 1 micron section, I've got the diagnosis. That's Fabry's. There is a differential. This is what it looks like on EM. All the podocytes are packed. You saw it on the tall blue. Are packed with things called zebra bodies or cytosegrisomes or autophagosomes. Those are all the same name. There's a perfect, this would be a board question. The hardest problem in this question is what organ am I in? Because nobody does electron microscopy anymore. That'd be the hardest problem, we'd get you into the kidney. And to know what this storage is. This could be any lysosomal storage disease by EM. Oh, that's great. Podocyte myeloid figure, that's another term. The place you see this and other disorders is in tubules and gentamicin nephrotoxicity. There are myeloid figures in the tubules in gent toxicity. That's really a bad problem of the mitochondria. There's your diagnosis. If you had a bathing trunk rash, they did a biopsy, so all you skin people, he's got angiomas. This is Fabry's disease. So there you go. They will ask you the question, if you see this slide, what is the enzyme defect? Or something stupid like that. That's so dumb. You're supposed to carry that around your back in your head when you look it up on that iPad I got over there? That's dumb as heck. All right, alpha galactosidase A enzyme is I don't remember that. I see Fabry's probably once a month. I don't remember the enzyme. We work with Sanofi Genzyme. We link up these patients with their clinical people. Now, here's what I mean about a lecture. This is actually what's on your slides, and we're stopping. You can go back now and read everything you want to know about Fabry's, because I put it in a lecture. But you know what? It's faster to look it up on the internet. Or if you've got it on this thing, it is fast, because it'll be just like a clickety-click through the deal. Guys, I've went 2 minutes over my time. No, I have 2 more minutes. I have 2 or 3 more minutes. What I want to do, we don't have time to go through another case. There's 2 more cases on here. There's one case that is so rare that, I mean, it's just off the wall rare. We get 6 a year. Now remember, we serve 39 states, 1,500 nephrologists, so we broaden out. We get rid of all bias by doing that. So we're actually a reflection of how many cases a year there are in these diseases. So there's 6 cases a year at Nephropath of this one that's on there. So there's a lot more fun stuff on there, and you can look at that. Any questions, comments, thoughts in the last 3 minutes? Or have I bored you so badly you're thinking, run for the door? All right, let me just say one thing. Part of what you need to know, and this is now I'm getting up on my soapbox. I'm on my soapbox now. You're in the best possible discipline today. This is the best specialty to be in. We are responsible for 80% of diagnoses now. Your life can be what you make it. I'm 67 years old. I am so active. I'm publishing more. We have a gigantic genomics research lab. We just opened our zebrafish research facility. We do more kidney biopsies. I got so many people that are young and exciting to work with. Pathology can be so fun. I know plenty of 40-year-old pathologists who are just dying to retire. That's their bad, right? This should be so exciting. We have the opportunity of a lifetime being pathologists. I love this discipline. I'm very glad you're in it. I look forward to hearing great stories that you've gone into cytology, cytopathology, and you're enjoying it. Approaching patients, helping them, to a fine needle. How important that is. You just, it's so important. Questions, comments on it? Bye, guys. Bye, guys. You stopped at 5 of. Like we're supposed to. I'll sit around for a while if anybody wants to. But you guys got places to go, things to do. Thank you very much.
Thank you.
Thank you.
Thank you so much.
Thank you. So thanks everybody for having me. We have our next lecture Monday, so that will be a term pet by Dr. Rajendra Singh. Thank you everybody.
Can I copy these?
Oh yeah, this is I left stick.